Thank you all for joining us today for our webinar today about redesigning health plan in some new and very effective ways. My name is Mark Delicave and I work for Quizzify. And I'm going to start with some introductions here and then turn it over to Al Lewis to lead the discussion. So Al, if you could move to the first slide here. Most of you know Al. Al will be leading our discussion today, and Al is recognized as one of the foremost experts on wellness and population health, and he's written a book specifically about that and the validity of corporate wellness programs and the outcomes. And in addition to that, Al co-authored a book with Tom Emmerich, who managed benefits at Walmart for more than a decade, and Walmart's been very much in the forefront of lots of innovations in healthcare. And that book was Cracking Health Costs that they published in 2013. And that was all about how Walmart's redesigned some of their healthcare for the better. Now, our special guest today is doing some great work with privately insured plans. And Dave Chase has authored many books about redesigning healthcare and produced films. But specifically what they're doing is educating brokers and advisors as well as employer groups on very specific methodologies that can create better healthcare plans and also make them much more accessible to the people that are in those plans, in the sense of removing barriers that most people can't afford, like high deductibles and excessive co-insurance payments. So we'll hear how Dave is doing that and some case studies. So without further ado, I'm going to turn it over to Al Lewis, who will get our discussions going.
All right, thank you very much, Mark. And we are going to start with some polling questions. Those of you who have been on our webinars before know that we like to ask questions of the audience. We're also going to do open mic. If you have a question you do not want to put in the Q&A, a lot of people just like to put them in the Q&A for anonymity. Just indicate that and we will open the mic. Now, we've never done this before, and there's a saying that, that you shouldn't try a recipe on company till you've done it at home, but we got to start somewhere. So let's start with the polling questions. Then Dave's going to show what a typical Health Rosetta plan looks like. We're going to add our little piece to a way of dramatically reducing costs for emergency care. And then we're going to talk about avoiding care. And then we got a couple of case studies lined up. Okay, so hit your polling buttons. Get ready to hit your polling buttons. And let's just take a little bit of temperature of the audience. In your last annual cycle, which was probably now for next year, 2022, which did you project for total healthcare? Is it going to increase, but you're keeping employee share the same? Is it going to increase, but you reduced employee share? Is the total spend going to increase and employee share will increase, or is it going to decrease? Mark, while you put that up, I'll ask, Mark, I'm not seeing it on my screen. Should I be seeing it on my screen?
I'm going to end the poll here. Okay, I'll share the results. Here we go.
Oh, okay, I didn't see the poll in the first place, but usually it comes up on my screen. So while you're collecting the results, I'll just ask Dave. Dave, what did the typical Health Rosetta plan do for 2022 out of these things?
Yeah, I mean, typically what we're seeing, it depends on how aggressive folks get, but typically you're going to see at least a 10% reduction. I'd say 20% is more common. And then the ones who are particularly aggressive will see even more.
Okay, so Mark, what did a survey says?
Yeah, I'm sorry you can't see it on your screen, Al, but the 57% said the increase and employee share will increase. 30% said there'll be an increase, but employee share will stay the same. And 13% actually said there'd be a decrease.
Okay, well I would just caution the ones who are increasing employee share that the market has shifted, as you've probably noticed. I mean, I just came back from Whole Foods and they're offering, $1,000 sign-on bonus and a whole bunch of other things that they weren't offering a year and a half ago. So careful of those employee shares, and that should make you considerably more interested. Obviously, you're interested. You wouldn't be on the webinar in what Dave Chase will have to say. So let's now go from the actual to the theoretical. Do you believe it is possible to both lower total spend and employee share? And I don't mean just like a one-time thing, but I mean literally over time, reduce both employee spend and employee share. So your choices are yes, a lot, yes, but just a little, no, or you don't have an opinion. And I will also, while you're collecting that, I don't know why I'm not seeing my screen. We've done these webinars a zillion times. They always show up. I'll ask Dave. Dave, how many years in a row does a Health Rosetta plan see a reduction? And I don't mean versus inflation or versus some wacky benchmark, an actual dollar reduction in spend and share before you get to the point where it starts to go up again.
Yeah, I mean, it depends on how many of the components, which we're going to go through, that they implement. Sometimes most won't do this, but some will rip off the Band-Aid and be very aggressive and get a 40, 50% reduction. And that's possible. But most will do it a step at a time. And so when they get through those steps, which is typically, I'd say most commonly, they do those steps over 3 years, they're getting reductions each time. But then once they've done most of those things just kind of level off at that point, and then things grow at sort of the rate of regular inflation, not the sort of inflated and mythical healthcare inflation.
But they're growing, the first derivative is the same, but the absolute number continues to be way below what it would have been.
Yeah, I mean, that's where you have like a Rosen Hotels where they've been doing it 30 years and, they did a lot of these things before. And they look smarter every year, even though they really haven't changed their spending much year to year. And so they're currently spending 55% less per capita with the best health plan I've heard of any company in America. But they're just not seeing big increases like most folks.
Right. All righty. Sorry, Mark.
In terms of the results of that poll, 61% a lot, 25% a little, 7% said no, and 7% had no opinion.
Okay, so actually there is some optimism in this group. Yeah, I'm sorry, Mark. Since I can't see it, I forgot to call upon you to ask what it was. Oops, let me see. I'm stuck here. Hang on a sec. There we go. So health equity is a big buzzword these days. And let's see how people define it. And then we'll once again ask Dave. Every employee so this is your goal for health equity, realistic goal. Every employee should be as healthy as possible. No employee should avoid needed health care for financial reasons. We can't significantly improve health equity or something else altogether. And while you're doing the poll, I will ask Dave, which one of these would you pick, and how do the Health Rosetta plans get to it?
Yeah, I mean, I would say kind of the first two. I would really say both are very applicable. And, our purpose, which I'll talk about a little bit, is what we call the Health Rosetta dividend, because we're spending nearly 90% of the dollars for what drives 20% of health outcomes. And yet, these things like having better pay and benefits and being able to live in a decent home and educational opportunities, these sort of things are actually what drive 80% of health outcomes. And so that's part of overall well-being.
Yeah, I would agree that overall well-being is definitely a goal, but the improving individual health using conventional methods does not seem to work. So what you're describing is what Rosen Hotels does, which is make the entire community a better place, an easier place to become healthy in. Mark, what did we get for the poll?
Our audience, 71% chose the second answer, no employee should avoid healthcare for financial reasons, and 26% answered the first, every employee should be as healthy as possible.
Okay, so yeah, I would vote for B, because I think B, as we'll see, is very doable. And actually, I think at this point I'm going to stop the share and then turn it over to Dave and we've teased health equity a little bit. Turn it over to Dave to share.
Okay, can you see my screen okay? Great. Want me to take it away?
It's all yours, my friend.
Okay, excellent. Well, the book that Mark shared that Al wrote, Cracking Health Costs, that was a really pivotal book in my journey early in this process. And so thanks to Al and to Tom for writing that. But what I want to talk about is I believe that because of a generational shift, a technological shift, I'd say COVID has accelerated this, that we're living through what I think will be the biggest single inflection point in our lifetime. And every employer, every community has an explicit choice to move forward or move further backwards, because we're clearly going backwards. And I'd like to take you back to a day, March 9th, 2016. See if you can remember that day. That was one of the biggest aha moments days in my an adult life is really crystallizing. It was the morning that I woke up to the news that Bernie and Trump had won the Michigan primary. And I was like, wow, this is unusual. And there had to be an explanation. And so I was already on this journey to some extent. And the book that I published about a year later has the first chapter of the CEO's Guide to Restoring the American Dream is America's gone to war for less than what the status quo healthcare system has done to America. And, in light of this electoral outcome, you started hearing the term populism more. And this is something I was like, what exactly is that? When does it rise? And populism tends to rise when there's economic depression. It's like, oh, bingo. What's it actually an economic depression? Well, one of the definitions is 2 or more years of wage stagnation and decline. By that definition, the working and middle class in America, tens of millions of people, have been in economic depression for over 2 decades. This is far longer than our Great Depression. This is longer than 1930s Germany. I was like, wow, there's going to be some crazy stuff that's going to happen. And I would call this current situation, this kind of misspelled health, kind of hell on earth health. That's what we are living through. And that's why this is part of the context for what I'm going to get into. And what I'd like you to do is fast forward, have you imagine a future, about 10 years out, where every community has what we just talked about. Every employer community, every place-based community can focus in on what I'd call wealth, again, misspelled wealth, because we know the greatest wealth is overall health and well-being, and not some of the bogus things that Al has written about, but truly the totality of health. Sometimes people call it the social determinants of health. Things like a good, well-paying job, educational opportunities independent of family means, and the ability to live in a decent neighborhood with clean air, clean water. Unfortunately, healthcare has stolen away resources for that. But the great news is we actually don't have to imagine the future. You can see it with your own eyes throughout the country, and it's happening from communities from Florida to Alaska, literally. And it's been proven over multiple decades in some cases. In other cases, and examples I'll give, generally, I don't really believe something until it's been in place in healthcare about 5 years, because you can just get lucky for a few years. And Al and Tom wrote about that. But let's unpack this. Probably the most common question that I get that I'll preempt is, why are you so passionate about this? I mean, I think some of what I just talked about would give you a feel for that. But let me just tell you a little bit of my own story. By the time I was in my late 30s, unfortunately, I had lost 10 friends, my age or younger. Of course, each one of those is a gut punch reminding us of how short our time is here. But the last one hit me particularly hard because it was a friend that had a similar career trajectory, had done the right things, had been pretty successful in Silicon Valley. She should have had access to great healthcare, but the wrong diagnosis, which is incredibly common, unfortunately, and a harmful treatment plan led her to being physically, financially, emotionally devastated, ultimately leaving behind a 10-year-old daughter as a single mom. And that naturally hit me hard. And I realized this was a complete system failure. And I'd been a part of this system. Of course, I didn't intend for something like this to happen, but I had started my career in what's called fancily today a revenue cycle consultant. It's just basically how can you jack a bill as high as possible. And at one time, that was kind of a reasonable thing. You just didn't want to forget to check particular boxes for, carrier reimbursement, but it's really run amok. And it's absolutely devastated America. And the way I was raised was, if you see a wrong and you don't do something about it, you're culpable. And what we've seen is this rise of the functionally uninsured. When your life savings are less than your out-of-pocket responsibility, you can look at these factoids here. We have over 20 years of wage stagnation decline. 60% of the workforce makes less than $20 an hour. Average family of 4 premiums are greater than $20,000, on and on. Like, this math doesn't work. This was a picture of a couple in an article in the Wall Street Journal where they're literally hunting and fishing more because they can't afford to buy protein at the grocery store. That's how far things have gone. And you look at the fact that we're the undisputed world leaders in medical bill-driven bankruptcy, and 70% of those people had quote unquote insurance. I don't think you can call it insurance if it doesn't protect you from bankruptcy. So this is a terrible situation. But fortunately, and where we're going to focus our conversation here, is there's a new day. There's a new day in America, in every corner of the country, rural, urban, public, private, large, small. There's great success stories. And we've written about these in my book. I'll have some links later on to a free download of those. But we're seeing something fundamentally different that is going to be the focus. And there's really 2 great pieces of good news here that most people aren't aware of. One is healthcare isn't expensive. Well, what do I mean by that? Well, I think most people would say the primary value creators are the clinicians, the doctors and nurses. They only get 27 cents of every dollar ostensibly spent on healthcare. And so what's expensive is price gouging, profiteering, administrative bloat, fraud, inappropriate treatment. And in Health Rosetta style plans, we just choose not to participate in those things. And that is a choice you have. And the second piece of good news is, fortunately, we're already spending enough money to not only fund a world-class healthcare system, but to fund or restore funding to what drives 80% of health outcomes. The social determinants of health that I talked about earlier. That's really at the heart of our purpose. And if we don't squander the $1.5 trillion with a T, which would be the 11th biggest economy in the world ahead of Russia, that's what we waste in healthcare, and that's a conservative figure. If we don't squander that, then we can provide incredible benefits like what the Rosen Hotels of the world do. And so that's really our focus. And, I would draw your eyes to this quote. This was about, Michael Lewis was the author with the book, The Big Short. This is about financial services. He talks about how, if it wasn't complicated, it wouldn't be allowed to happen. The complexity disguises what's happening. If it's so complicated that you can't understand it, then you can't question it. Healthcare doesn't need to be complex, at least from a health plan perspective. Another way of looking at it is from economist Thomas Sowell. People will pride themselves on their complexity and deride others for being, quote, simplistic, should realize the truth is that often it's not very complicated. What gets complicated is actually sort of evading the truth and hiding the truth. And what we're about is proper disclosure, proper transparency, alignment, these type of things that actually make a real difference in people's lives. Hang on a second here. Our screen is not advancing, so. Okay, here we go. So what our mission is about is what we call empowering community-owned health plans. It's really this ownership mindset, not renting a Wall Street sick care plan, but actually owning a true health plan. If every employer did what a Rosen did, some of the other employers I mentioned, it would be like a recurring $500 billion stimulus into our economy. That's the kind of power that it has. Again, we're seeing this all over the country. And, I like this Churchillism, Americans will always do the right thing after exhausting all the alternatives. Well, these folks, the Rosens, again, they're spending 55% less. I had a TED talk about them. The pipe trade unions in Minnesota, where there's 16,000 members, even though only 25% of their members have actually started using their primary care clinic, and that's the primary thing, they haven't seen overall healthcare spending go up in a decade. Pacific Steel and Recycling, they were spending over $8 million on health benefits. They improved their health plan, reduced cost sharing, did a bunch of direct contracts, and got rid of profiteering in the pharmacy area. They are currently spending $3.5 million. The NUCA model, the only two-time winner of the Malcolm Baldrige Award, which is sort of like the Nobel Prize of business, incredibly challenging circumstances and doing incredible work there. These are the types of things. Again, we're seeing these spring up all over the country at various stages of development, these community-owned health plans, and we're super excited about it. And so it's a 5-step process to do this. Again, it doesn't need to be complicated. When you look at these 5 steps that spell out this acrostic, that spell out local, because what's more local than an interaction between a doctor and a nurse? 4 of the 5 steps are invisible to the member or clearly a positive. Sometimes people say, I don't know if we want to change our benefits, it might be disruptive. Well, we can put aside for the moment that being the undisputed world leaders in medical bill-driven bankruptcy and our health plans, our employer-driven health plans, gave us the opioid crisis, gave us the benzos crisis. I wrote a whole book on this. That sounds pretty disruptive to me, but again, change is change. So we have this process where it doesn't have to be disruptive at all. The last step is the one that if it's not done in the hands of a professional, it can be disruptive. If it's done in the hands of a professional, the right kind of rollout, like what happened with Pacific Steel, then it's actually a huge benefit. And I'll talk about that a little bit later. But these are the 5 steps. The first one is just a mindset shift. Most people think solving healthcare is like trying to solve Middle East peace. They like that solved too, but it seems kind of hopeless and out of their control. That's the biggest thing. Until you have that mindset shift, nothing happens. Once you have that mindset shift, everything is possible. And I talked about earlier this kind of ownership mindset versus a renter mindset. And it's really remarkable what happens when you do this. The first step, frankly, is kind of boring, but it's kind of the master key that unlocks the other doors. There's some savings to be had here, but these are the types of things of who's the benefits advisor, benefits broker you're working with? Are they actually on your side? Do they disclose everything? We published this benefits advisor compensation disclosure form. It's actually kind of became a model for what's going to kick in shortly because of the new broker compensation law. We have an benefits advisor code of conduct, a plan sponsor bill of rights. These are things, if you're new to the industry, as I was, at least to the health plan industry, several years ago, you'd say, what's the news here? Well, unfortunately, it's a polar opposite from the way most people have operated. And so you get these things right. Copper State's one of the case studies in the book. Before they did any of the subsequent steps, with pharmacy and primary care and how they contract for provider access, they found $1,000 per employee per year of savings, getting rid of junk fees, actually watching claims, and a few other things that I spell out in that case study. So there's a bit of direct savings, but you got to do these things to open the other doors. One of the biggest ones is, yes, Al.
Yeah, could you go back to the disclosure slide? I find that that money is going under the table for things like if a large consulting firm has actuaries, a vendor will, instead of just bribing the consultants directly, they'll pay them some big fee for the actuaries to quote unquote show savings. Is that covered in this disclosure form, this kind of indirect bribery?
Yes, it's both the direct and indirect. We found, and it's probably higher now, but we found the 17 different undisclosed revenue streams. And that's one of the things that, we were speaking yesterday, in fact, with the people putting in the regulations and doing the rulemaking at the Department of Labor. And they're following the model that was put in place for pensions back in 2011 that was getting at these kinds of shenanigans. And so it's gonna initiate some awkward conversations out there. And so absolutely it is intended to include those indirect sort of non-account specific bribes. So it's pretty horrible.
Yeah, I mean, without mentioning the name of the consulting firm, there's one consulting firm that says that smaller vendors like us need to contract with them to learn how to calculate an ROI, which means basically we bribe them. And of course, using these guys to learn how to calculate an ROI is like using Tom Brady to learn how to inflate a football,
Said by a New England Patriots fan. Great question. And you want to talk about undisclosed fees. Boy, the PBM arena is riddled with it. The good news is there's so many shenanigans going on here. We've found over 30 different revenue streams that PBMs have generated for themselves that most employers would think maybe they have one or two if they even know what a PBM is. State of New Jersey, for their employees plan, there's about 800,000 employees. In the first 3 years, they saved $1.6 billion with a B. Caterpillar, really about the only thing they've done on their health plan that's sort of Health Rosetta-ish is they've been very hardcore on their pharmacy procurement because they know how to manage supply chains and procurement. And they haven't seen overall healthcare spending go up in a decade because of being so thorough. And it's worth mentioning, in their case, they did change the formulary. When I say it's invisible to the members, you can do things that are invisible to the member, like where you're not changing the formulary, you're not changing where you're picking up the drugs, and still get a bunch of savings. There's even more to be had if you update the formulary. There's a lot of junk drugs that are like, take 2 over-the-counter drugs that might cost $14, put it in 1 pill and charge $3,000. So there's opportunities like that. Pacific Steel, about a quarter of the savings that they achieved was in the pharmacy area. So this is a really easy one to do. There are good PBMs out there that properly not only disclose, but actually get a good price. But in fairness, if you know how to procure well, you can actually get one of the big 3 PBMs to give you a fair price. Most just don't know how to procure well, which is one of the things that we train people on. The next thing is add value-based primary care, or what's increasingly called advanced primary care. A little bit like the O in local, it's also kind of a master key that unlocks other doors of savings, but there's some direct savings opportunities. If you look at the case studies here, these are organizations that are in most cases spending 40 to 50% less because there's a lot of unnecessary ER utilization. Half of ER's visits are not an emergency, but we've just destroyed primary care in this country and made it hard to access. And so once you rebuild primary care, which is a very straightforward thing to do, then 50% of the ER visits go away. Between 30 and 50% of surgeries go away. There's a lot of unnecessary surgery. I know Quizzify has some stuff around lower back pain and inappropriate use of opioid prescriptions, inappropriate lumbar fusions. So there's some direct savings if you get great primary care, but it also, when you have a complex medical situation, it helps to kind of have a quarterback, a Sherpa, whatever metaphor you want to use to help you guide you through the system. The final step is where the biggest payoff is. These are organizations that have done some of the direct contracting. Some of them are doing reference-based pricing, which is kind of a bridge to that. And one of the things that Al and Tom wrote about, that then Tom wrote a chapter in my book around centers of excellence. If you go for these complex medical situations like organ transplants, they found that Walmart found that 40%, 40, of the planned organ transplants were medically unnecessary when they took people to a place like the Mayo Clinic for a second opinion. Any other context, we'd probably call that assault. And there's other things like what my friend experienced, a wrong diagnosis will lead to a wrong treatment plan. And even when there was the right diagnosis, when you send them to a centers of excellence, 40% of the time, they make a meaningful change to the care plan. And so you're going to have cancers, you're going to have these things, but it's very easy for a cancer that might cost a plan 100 or 200,000 to turn into a $1 million or $2 million claim. So those are the sorts of things that, again, you got to be very thoughtful on how you do this, but this is where the biggest savings exist. So just wrapping up here, what's possible when this speaks to the purpose I mentioned earlier, what we call the Health Rosetta dividend. When you no longer squander money, the $1.5 trillion that we're squandering in our healthcare system, you can readily afford to give great primary care access. You don't need copays and deductibles and co-insurance. When and I would sum up a lot of plan design is you make good decisions free, like going to great primary care, you make bad decisions expensive. And there you could have deductibles, but for smart decisions, you don't want to put barriers. And these are the sort of things that different employers are doing different things. Some are providing college education, family leave, free or subsidized healthy meals. Again, that's up to the particular organization, what they want to do. But once you're spending so much less, you have the opportunity to pour it into the things that drive 80% of health outcomes. So last slide here, and I think we'll go into questions, is you can download my books for free. There's executive summaries for the CEO's Guide and Relocalizing Health, which is my most recent one. If you're only going to download one, I do Relocalizing Health because they kind of build on each other. And you also get a weekly email that kind of is a sort of cliff notes on each chapter. So with that, look forward to the questions that Al and Mark and you all have. And so I'll stop my share, and Al will probably share a little bit of more on Quizzify too.
Yes, I would, but we have a few questions already. And if anybody wants to go live, just let us know. One is, this seems to be done most by smaller and middle-sized employers, with the exception of Caterpillar. I didn't see any large companies up there. And Caterpillar is only doing the PBMs.
Yeah, so I mean, any employer can do this. The pipe trades union, there were 16,000 folks. The advantage they have is they're in one location. And so if you've ever read Clay Christensen's work on disruptive innovation, there's this misnomer in healthcare that if you want to change healthcare through the employer lens, you got to go to the enormous employers. And I'm all for them doing things like what Walmart's done, Whole Foods has done smart stuff. You're seeing some of that, certainly Caterpillar, the state of New Jersey. But the reality is, those are really complex, multi-location, multinational organizations that typically change on 3 to 5 year cycles. And so these organizations in sort of the 50 to 5,000 range is really where the greatest amount of activity is going on. And that frankly, they can't afford to be sloppy. a lot of the big employers who are very profitable can afford to be sloppy, and have been hoodwinked into thinking it's not possible to solve healthcare. So anybody can do it, but the reality is the mid-market is where the greatest innovation is happening right now.
Okay, Mark, anything else come in, or should I?
Dave, here's a question. What's the single biggest barrier for employers to getting the most value from their health plans?
It's really that mindset shift. And then once they've had that mindset shift, the reason for Health Rosetta, that the tip of the spear for us was this accreditation program for health benefits advisors or health benefits brokers. That's probably the most underestimated role in the entire US economy. They're incredibly important. At their best, they're worth their weight in gold. And so about 18% of the folks who applied into the program in Health Rosetta have made it through. Some just aren't ready yet. So that you can't, once you've had that mindset shift, you can't get the job done without a great benefits advisor, benefits broker. And unfortunately, the way that they have been compensated is radically broken. This recent legislation is going to force a huge change on that. And we're gratified that we were a catalyst on that. But that's really the key thing.
Okay, with that, picking up on a point you mentioned about Quizzify and emergency care, we have one more polling question. Which is most true about in-network hospital costs? They are generally a somewhat higher Medicare, multiple Medicare for electives and emergencies. The opposite, emergencies cost much more than electives. There is variation among in-network hospitals, but almost none are lower than 180% of Medicare. So while you are answering that, Dave, what is your sort of typical direct contracted hospital as a percent of Medicare?
Yeah, what we find is that 98% of the time, if you pay 150% of Medicare rates, there will be no pushback. And Medicare by law requires hospitals to report on their costs. It was like the savings. There's some funny ways people define savings. Like they'll define savings as a less bad increase. And they'll say, hospitals will say they're, quote, losing money on Medicare. And they're only losing money on Medicare if they're incredibly poorly run. But they have to report the costs to CMS under, a law. So to make 50% more than Medicare is a great deal for most of them. And now and again, you can't get the job done. And so 2% of the time, actually less than 2% of the time, you negotiate. And sometimes you'll lose a battle to win the larger war. And but the best thing to do is to, if you look at hospitalizations other than automobile accidents and maybe childbirths and a few other things, if you go upstream enough, almost every hospitalization is avoidable. So the best thing is to avoid it or get care in the appropriate place. A lot of the times that's an ambulatory surgery center, and then have a fair price when it is at the hospital.
And Mark, what do we have for the polling?
Well, 81%, there's a variation among in-network hospitals, but almost none are below 180%. 15% said the opposite, emergencies cost more, and 4% they're generally somewhat higher than Medicare.
Well, I got to say, my experience, and I've looked hard at this, is that there are hospitals, as Dave said, quite a number of hospitals actually that are lower than 180% of Medicare, particularly for electives. So I would personally vote. I mean, this is a polling question, no necessarily right answer here, but I would personally vote for B, and I'll tell you specifically why, and that'll bring us into the next Quizzify item. And actually, I'll share my screen. Well, let's before we do the next Quizzify item, let's also poll the audience on this. What is your average allowed claim? Now, remember, your employees are getting stuck with a big piece of it. Maybe they haven't paid their deductible. Maybe you got a high copay. So we're looking allowed. What is your average allowed claim for an ER visit? And as you know, the physician bill comes in separately, and sometimes there's another bill that comes in. So we're looking at everything combined. Is it over 2,000, 1,000 to 2,000, under 1,000, or you don't know? And while you're waiting for that, I will describe why, in fact, emergency expenses are generally a much higher percent of Medicare than electives. And I just learned, I noticed it. I mean, I've seen it myself because we do a lot with emergency care at Quizzify, but I had no idea why it was always so high. And I read, I don't know how many of you follow Dr. Eric Bricker, but he writes this stuff, seems like every day, and it's pretty amazing. I don't know how he does this. I don't know how he does his day job. But he pointed out that the Emergency Medical Treatment and Active Labor Act of 1986, EMTALA as it's called, essentially made hospitals responsible for emergency care for even people who couldn't pay at all. And as a result, they jacked their prices way up for emergency care for people who could pay. Now, for elective, you know, if the hospital's not in the network, if you can't pay the bill, they just send you somewhere else and you're done. So, Mark, what is the poll result here?
Okay, 38% said greater than 2,000, 23% said $1,000 to $2,000, and 38% they don't know.
Yeah, I was wondering when you did the first two, Mark, I was thinking, oh, it can't be the case that people think it's under 1,000. So basically 0 out of the 180 people have registered, well, some of them didn't come, for this webinar had under 1,000. That is absolutely right. It's usually over 2,000, sometimes way over 2,000. We will put the kibosh on that totally through what we call a Quizzify to Go, our ER sticker shock prevent consent. You simply download it. We have not gated it yet, so anybody can do this. You download it from here. It will show up on your phone. It will tell you, do you want to save this to your home screen? It will show up with a big Q. And then when you click it open, it gives you two options. One is the ER sticker shock prevent consent, and the other is questions to ask your doctor or dentist. Both are unique. This one, frankly, is gated because we were getting a ton of use and we wanted to reserve it right away for customers. We have more than 100 topics now where we have a full set of questions. You just put in a keyword and it gives you the questions to ask during the doctor visit. You can put them on your calendar. It links to the Quizzify quizzes that are specific to that topic, yada, yada, yada. But let's talk about the prevent consent. Now, in this previous slide, we got 0 saying under $1,000 for an ER bill. Now, if there's one thing that Medicare is really, really good at, it's negotiating, it's setting rates for emergency care. For starters, you don't get 2 bills, you get 1 bill, okay? Second, Dave mentioned that you can negotiate 150% of Medicare. Well, that's all in. That includes things, that includes emergency and elective, right, Dave? I mean,
yeah.
The emergency care, we feel like you're getting a really good deal if you're at 2 times Medicare, as we call it, 200% of Medicare, because the typical thing we see is 3, 4, 5, 10. I think our record is something like 27 times Medicare. And that's in network. That's in network. So we have this thing called the prevent consent. We say, do not sign the financial consent for treatment. This is an old slide. I'm sorry, we fixed the grammar there already on the actual app. Instead, you write this in. It's the ER sticker shock prevent consent, superseding other consents. That's in case somebody accidentally, they make it, by law, you have to have a treatment consent and a financial consent. The ER has a way of kind of putting them together. You still have to sign twice, but it's like, how many things do you sign twice and don't think twice about, right? No, these are 2 completely different signatures. So you have to learn to have it printed out. Oh, okay, first of all, let me just go through this. So you consent to responsibility, including insurance, for up to 2 times Medicare, following receipt of an itemized bill for appropriate treatment. we have now added, I don't know why I have the old version of this slide in here. We've now added coded to the correct level, because even though, as Dave says, there's ridiculous numbers of people going to ER for things that really aren't emergencies, the ERs are still have figured out that, in fact, they can just upcode this stuff and make it sound like an emergency, and get the highest level of reimbursement. So we're putting the kibosh on that. But the important thing is here that you are consenting to treatment for a number which is much lower than what the ER would normally charge. In fact, we basically, if everybody said that it's the average is more than $1,000, we actually will guarantee that you will not spend 4 figures allowed claim on an ER visit, period. Because Medicare, like I say, I don't know how they do this, their rates are so low that even when you double them, you're still in the 3 figures. Now, people have to know their rights. And that's why we have this whole section here on printing out the consent, writing in this language. If they object, you take a picture, record the conversation, demand to see the supervisor. You point out that according to law, they have to treat you. And if they still object, don't sign theirs and insist on being treated. One thing, a lot of this stuff is user-generated in Quizzify to go, and the user-generated item for the ER, mostly in the doctor visits, is, they're asking you for your social security number. You don't have to give them your social security number. They're just going to use that to ding your credit. Okay, like when somebody told me that, like the light bulb went on. And we have a support number in case you have issues. Now, curiously, we have, and this has probably been used 200, 300, even 400 times by now, 0 ERs have rejected the consent. So it will be accepted, you will be treated. What may happen afterwards is that they conveniently, quote unquote, forget that they accepted the consent, and they send you a bill for discounted charges. We have support for that. That's simple contract law. By treating you, if you sign something that says I'm paying 2 times Medicare and they treat you, that's offer and acceptance. That's the first day of contract law in even unaccredited law schools. Is if you go to a a restaurant or something and you order off a menu, you have accepted their offer. You don't have to put it in writing. It's the same with the ER. If they treat you and they don't object, they've accepted the consent. Okay, I notice we're getting some more stuff in here, Mark. So what are we saying?
Well, there's one comment here from Aaron Davis about one of the problems with the in-network ER is that you get an out-of-network anesthesiologist. And would you just elaborate on how the prevent consent deals with that?
Yes, 2 different ways. Well, first of all, that is one thing that the surprise bill legislation will put kind of sort of a kibosh on it. The surprise bills that will go away, and this is good law. I don't want to, just like Dave, you were saying about the disclosure law, this is a good law, but it will take astronomical bills down to unacceptable levels. So you go from astronomical to unacceptable, which is a huge improvement. And that will cover out of network as well as in network. This consent, it makes no difference whether someone is out of network or in network. You are, when you say 2 times Medicare, you are getting a bill for 2 times Medicare. It does not matter. It's between the anesthesiologist and the hospital at that point, because Medicare very clearly says 1 bill. And Mark, I think we got some other stuff too.
Yeah, maybe we could circle back to what Dave was talking about. And Dave, you mentioned a bunch of different case studies, and we in advertising this webinar, we talked about health equity and how redesigning your health plan could actually bring real health equity to the people on the plan. So would you maybe give us an example, one of your favorite case studies, and then another one that really is addressing this issue of health equity?
Yeah, I mean, the ones that I'm really drawn towards are like when there's teachers and school staff, or like hotel personnel, people who are providing a really vital service and aren't getting the highest compensation. And so there's both a large and small case study around schools. There's a rural school district outside of Denver called the Bennett School District. There was no primary care available in that community, and they had to go 45 minutes to Denver. Now there is with the direct primary care provider. They've done some of the other things we've talked about. We actually have a webinar and a case study on them. They're spending 40 to 50% less than they were before while waiving cost sharing for members. And they're just about the only school district in Colorado to have been able to give their teachers raises in the last couple of years. At the other end of the school spectrum, there's a case study around the Allegheny School Consortium. It's a bunch of districts around the Pittsburgh area, and there's a notorious price gouger in that area. And it was quite fascinating how the union and management got together, and the result is they're spending 40% less than their counterparts in the Philadelphia area while they've improved benefits. That means for a cohort of kindergartners in that area, for the 45,000 plus teachers in that community, there's $2 billion more available through their K-12 years. Consequently, they have 4 times as many librarians as Philadelphia. They've got smaller class sizes. These type of things that really impact our kids in future. I saw Carl Schuessler was on the list here. There's a case study of Gasparilla Inn, kind of a small inn in Florida. And it's basically good care is free. They don't have to worry about things that might have bankrupted them before. So those are the sort of case studies that I love. And another one on the school front that we haven't published, but is recent that I love was there's an advisor out of Northeast Ohio. This is kind of a stereotypical Rust Belt part of the Midwest. The economy's not been great. The school district there, despite the rough go they've had the last couple of decades, all the school levies had passed until the one earlier this year. First one did not pass in 21 years. That was bad news. The good news is a little over a year before, they'd put in one of these style plans and they'd achieved savings in that first year that was more than the total school bond. So they didn't have to cut benefits, teachers, programs, et cetera. So that's the type of thing that really is making a difference in people's lives, not only the staff, but their community at large.
Mark, I'm seeing another one here about the ER is outsourced to specialty firms, and that makes the base in-network costs go up. The surprise bill legislation that applies to ERs uses in-network costs as a proxy. So when you're forced into arbitration, because there was some out-of-network thing, they're looking at the in-network price. If you raise the in-network price, then you're basically raising prices. Here's the thing. If you don't sign the consent, you're not sent to arbitration. Something called the 7th Amendment. Okay, you have to sign away your right to a trial in order to be forced into arbitration. A trial can use Medicare as a benchmark, and hence the 2 times Medicare thing. In arbitration, the surprise bill law in a SOP to the providers does not allow the plaintiff, i.e. the patient, it's not technically a plaintiff, if it's arbitration, does not allow the patient to reference Medicare at all, because they know full well, the providers know full well how low Medicare is. Mark, anything else? I don't have my glasses on.
Dave, you've really set out a roadmap, and on our call we have a fair amount of brokers, advisors, as well as employer groups. So if somebody is really starting to think about the reality of this and wants to make some changes either in their advising capacity or as an employer group, what are some of the next steps? What's the low-hanging fruit to go after, and how do they get educated on what to do?
Well, first, get the right advisor. You can go to healthrosetta.org/map and you can see advisors around the country, the case studies that we've talked about, the advisors that are a part of those, whether it's, Rachel Means or Carl Schuessler or, any number of advisors around the country that are doing great work. That's the key thing. And then once you're working with them, they're going to look at your situation and, provide recommendations on the lowest hanging fruit. Something that we're rolling out within the Health Rosetta community is something we call Plan Grader. And it actually looks at the 40 most important variables in a health plan and comes up with a set of custom recommendations. And so that's something that some of the Health Rosetta advisors are now going to be putting in place. And so that's a tool as well. It goes through lots of questions of like how the PBM contract was set up and what benefits you have and whatnot. And like I said, there's about 80 questions, 40 that are really the most important variables that derive value in a plan.
Mark, anything else?
Well, and Al, there's a question about how do you get employees to use the prevent consent? I mean, this is a process. It's a very straightforward thing to do, but I'm sure that there's, how do you get employees to actually use the prevent consent?
Well, at first, and just to do a 30-second shameless plug, we basically guarantee that you pay for all of Quizzify just on the savings of the prevent consent. And you only need, depending on the size of your organization, 10 to 20% of employees to actually use this thing. So we know the human nature being what it is, you're in the ER, you forget. Okay, so way number one is, frankly, you bribe them, you pay them. Okay, you can cover their copay if they use the prevent consent and still be way ahead of the game. When we calculate savings, we calculate on the basis of actual savings, not, in the wellness industry, the Wellness Trade Association specifically says you can't count incentives against the savings. No, it's a payment. Of course you should count the incentive against the savings. So that's way number one. Way number two is we get people to, we ask a lot of questions about it in regular Quizzify to remind people. We also get, way number three is we also get people to use the rest of this, consent, the questions about the doctors, to take it with them, because only 1 out of 6 people will go to the ER in a year, but the average person goes to the doctor, calls or goes to the doctor and then 6 times a year. So you get people used to the thing. I'm just looking at the time, so I'm not going to go through the very last question because I want to make sure that we get any, the very last slide in the polling question here, because I want to make sure we get any other questions for Dave in before the hour ends.
Well, there's one question that's more of a detailed question, and maybe we'll follow this up. Maybe there's a quick word, but what about psychologists, anesthesiology providers, and organizations like the Cleveland Clinic? Does a plan just eat these 1,000% of Medicare charges and focus energy on savings elsewhere?
Okay, so the Cleveland Clinic, if they have an emergency room, they're subject to the prevent consent. I don't believe that a psychologist would not be part of this at all. I mean, if you go to a psychologist, you got to pay the psychologist. The anesthesia is covered by Medicare, the 2 times prevent consent rule. So anything else, Mark, before we wrap it up?
No, I think we've importantly explain to people where they can go to learn more about using some of these Health Rosetta methodologies. And what we'll do to follow up this webinar is make sure everybody gets a recording, whether you attended or you had to leave early, you'll get the full thing. And we'll include all the links and everything so you can, if you'd like to begin to learn more about some of these specific methodologies. There is a question here, Dave, about does Health Rosetta and your education, do you recommend specific vendors for employer groups to use or for brokers to work with?
Yes is the short answer. The longer answer is we track about 2,300 different vendors. there's 100 plus that there's been a good experience with it within our community, but it's situational. There's probably 2025 that I guess you'd say we'd put our name behind because there has been a deeper level of diligence on them. Even within those, though, we don't really give blanket recommendations because it varies. Like there's some TPAs that are great for over 1,000 employees and that's all they serve, so yes, that is a big thing that we get involved in. That's a big reason why advisors join our community, is to be able to share their experience and then also tap into the diligence that we do on particular vendors. And we don't take, importantly, to practice what we preach, we don't take payment from vendors. You could imagine the fact that we collectively, our advisors represent about 5 million lives. There's plenty of folks who do want to bribe us to have access to them. That would be a conflict of interest for us. And so that's not something that we do. But the ones who've earned their way in through great work that they've done with people in our community, and we've been able to shadow implementations and other things that we have as a part of that vetting process, we'd love to shine a light on them and create a good problem for them they'll have a lot of business to deal with.
Okie dokie. Well, thank you very much. And thank you for everybody attending, especially to our special guest who we've known for years, and we're thrilled to have him on. Dave, appreciate it very much.
Absolutely. Great to be on. Honored to be here.
I guess it's a wrap.
Thank you.
All right. Thank you all.